psychiatry. That is a little bit of history. I think it was stumbled upon by John Cade in 1949 about the effect of lithium carbonate on a person with bipolar mania. So that is how people understood that medication could actually help in managing psychiatric symptoms. And then in the early 50s, chlorpromazine, the first synthetic drug, was produced, and that kind of revolutionized psychiatric care across the globe. And the antidepressant effect of imipramine was also identified. And by the end of the 60s, I think we had at least one specific drug in each of the groups that are available now, like haloperidol or clozapine, benzodiazepines. Almost, we had a huge list of drugs that are still valued and used widely. But again, what is the purpose of these medication? Yes, it is more for symptomatic relief, make people feel better. Now, these medication, they not only provided relief, it also helped people understand the concepts about psychiatric illness. It slowly changed the way people understood psychiatric disorders. It helped people to, it kind of improvised on how we diagnose. It became more refined. New research models evolved, and psychiatry gradually moved away from a semi-scientific or a non-scientific stream to mainline academic medical specialty. That was one of the good outcomes of the discovery of psychiatric medication. It helped us understand how how the brain functioned and how mental illnesses were caused. So what exactly do these medicines do? The first and foremost thing that the medicines do is that it brings substantial relief from a lot of symptoms. It could be auditory hallucinations, it could be mood swings, it could be irritability, it could be sleeplessness, depressed mood. It can bring substantial relief. So how does that happen? The medicines act on the neurotransmitters, and I think some of you might be familiar with the various neurotransmitters in the brain, which are all implied in the management of psychiatric disorders like dopamine, serotonin, GABA, glutamates, acetylcholine, and so on and so forth. So all these medicines, they act on these neurotransmitters, not all on all neurotransmitters, each with a specific purpose, but then and it can also influence, it can also alter the gene expression and protein synthesis over a period of time. After use for a period of time. Unfortunately, though symptomatic relief happens, these symptoms can come back once medication was stopped, because it does not alter the course of the disorder. It does not have a lasting positive psychological effect when the medication is withdrawn. But how has it helped in research? Researchers have understood psychiatric disorders by breaking down very complex behaviors into very small, discrete behavioral units, and they try mapping them over neuronal networks, because using psychiatric medication has helped us understand the effects of the different medication on the different brain systems. So they try mapping them on the neuronal network, but unfortunately, this does not have any clinical relevance because it doesn't help in clinical management. So that research stays, and it has not progressed to help us clinically. But the translational research models, so what is the outcome of this is, it is a one-size-fits-all kind of approach that we have when it comes to medication. It is not individually tailored. And so some medicines can work for some people, it may not work for others, and some people can recover and some may not. So all this is because of this one size fits all, which is all that we have with us now. So the translational research models are trying to uh, bridge the different areas of researchers, connecting them with each other, and also trying to get a bigger picture so that it can help the community at large. More advanced research is now happening on pharmacogenomics, which is getting personalized medicine. When I say personalized, it is not individualized, but it is personalized to a smaller group of people who share genetic material. So it addresses people who have a specific genome. The genome mapping is done, and how the genetic inheritance affects the body's response to drugs, which will help us in choosing the right drug, the right dose, assure safety, better medication, and most importantly, adverse reactions are minimized. And the cost of the treatment also comes down, but these are still in very nascent stages and are yet to come into practice. So with all this, we all know that there are so many questions around medication. And that is one of the biggest problems that we have, addressing the myths about psychiatric medication. So when in the first phase, yeah. So usually people who come for the first time, they are very, very uncomfortable about taking medication because it is seen as a sign of personal weakness. But then that is not a problem about the medication, but it is about the psychiatric label that they find very, very disturbing. So that is an issue with stigma and poor conceptions about mental health in general and mental illnesses in the community. And side effects. All psychiatric drugs are attributed to have serious, irreversible side effects. The first thing that the question that arises in a person's head when we talk about prescribing medication is, will it affect the kidneys? Will it affect the liver? Right? Unfortunately, people who ask those questions are not aware that such a simple, safe paracetamol, if abused, can lead to renal failure. It can lead to liver failure, but that doesn't seem to be scary. Whereas a tablet of haloperidol definitely puts the fear of serious complications in them. But the fact here is all medicines have side effects, some of them beneficial, some of them not so good, and not all of them are irreversible. Once the medicine is stopped, most of them can be reversed. So this is a myth that needs to be addressed. And I think these are all some of the issues that Ekalavya will be addressing in their awareness, I'm sure. On the other hand, we also have people who believe that medication is the one-stop solution for all psychiatric problems. Like it's just you pop a pill and you become completely all right the next day. No, that kind of a myth also exists about psychiatric medication. And it can make one dull, dependent, and completely unproductive because they're all sedatives, habit forming, and it can lead to addiction. So they can never live without medication. So these are all the various myths that people do have and which causes a lot of anxiety, which is probably one of the reasons why people drop out of medical treatment. And the more common myth is alternative therapies are always safer and are more beneficial. When I say alternative therapies, it can be naturopathy, it could be homeopathy, or it can be a simple magico-religious treatment that can extend from a very small temple nearby to a place or a dargah where the patient goes and speaks about. Uh, I'm sorry. And one of the bigger fears that people with mental health problems do have is that these medicines can change who I am. I'm a certain kind of person, and once I take medicines, my brain is completely altered, and I will no longer be the person I was. That is another myth that is strongly held by young people, especially when they come with the first episode of a psychotic illness. And the other fear is once we start it, we can never stop it. So with all these are some of the, oh, what's happening? I'm not able to move my slide.
We can see and hear you, doctor.
No, but I was not able to move my slide.
There you go. It's
Yeah. So these are some of the questions that we come across in different phases of the of any psychiatric illness. In the acute phase, it is usually the families which have a lot of questions. How and when should we take the medication? And of course, that was it because of me? How am I responsible in some way, or how should I respond? How do I behave around him or her? But if you see, the highlighted questions are about the medication. What are the side effects and how long should they be on medication? And once the acute phase is over, when they are becoming a little better, the person who is on the medication will have questions of their own. So I'm gaining weight. I have acne. I have hair fall. I'm having problems in concentrating. And finally, it comes down to how long will I have to take the medication? And in the remission phase, it is always like, I'm doing well, so why do I have to take medicine still? And then there is concern about the symptoms happening again. And when that is explained, they still want to try stopping medication because being on medication is more stigmatizing than experiencing symptoms is what, because being on medication means you are constantly in contact with a psychiatric facility, which is not comfortable for young people, especially. Maybe after a few years, they might kind of feel comfortable, become more, find the therapist or the mental health professional a little more friendly, but then it is very, very stigmatizing for them to be associated with the mental health facility because there is a difficulty in accepting the diagnosis. But there are two questions which most mental health professionals have no answer when it is asked. Why me? And
trains and stations.
Why me will be from the patient, and who after me will be from the families who have to take care of, elderly parents taking care of their wards who have a serious mental health problem. This is where the concept of rehabilitation kicks in. So rehabilitation is more about recovery, whereas medication is more about symptomatic relief, where we focus on the problem. In rehab, the focus is more on the individual. So what we are trying to do here is help people who have some difficulty in functioning in a particular way so that they are able to stay in tune with their environments and lead a normal life. That is all rehabilitation is based on. So the focus here is more on their ability and not on their disability. So we are trying to discover what their skill sets are, build on it, give them hope, confidence, and a motivation, and finally, help them get a sense of achievement. How do you do this? This is not a one-off kind of thing. It is an ongoing process, and it doesn't begin after medication treatment is over. It starts the day a person comes in contact with the mental health system. That is when it is going to be effective. All those questions about medication, I don't know how many of you have felt that the psychiatrist is available for answering all those questions that you have in your head during a consultation. I'm not sure if it will be possible, and I'm not sure if you will have time to discuss it with a psychiatrist every time you go to meet them. Because in a psychiatric consultation room, the focus is more on getting symptomatic relief. That is where the psychosocial rehabilitation team will step in and help us in understanding how medication can be helpful. So we are not just looking at other areas, including improving medication adherence and using that to improve further in life, focusing on their strengths, skills, all this. And all this is not a single person's job. It cannot be done single-handedly. You need a team. So it's a group of people. It could be psychiatrists, psychologists, social workers, occupation therapists, nurses, community level workers, you name it. And more importantly, now I think we have a lot of people with lived experiences who have joined this journey. They have joined into the bandwagon to help people in the recovery process. So what exactly happens in psychosocial management in all the three phases? In the acute phase, it's more, psychoeducation to focus on medication adherence, make sure that we are able to just listen to them. A supportive counseling will go a long way, especially, I think some of these things are more applicable for people with the first episode of psychosis, because that is the time when there is a lot of denial. People are not ready to accept that they need to be on medication, especially when we say that it has to be for a period of 2 years minimum. It is very, very difficult for them to accept. So we need to constantly be hand-holding, educate them, make sure that they are regular. It will be on our heads to keep following them up, right? And excuse me. Prepare for reintegration or work or community. Once the symptoms are better, we want them to get back into their previous routine. And of course, the side effects are there. So we need to keep a watch on the metabolic side effects. And psychoeducation continues. The psychoeducation, the content will vary according to the phase, but then the process of psychoeducation remains at different points by different people for different needs. And the family involvement is very, very important, because India does not have the luxury of a system which takes care of every individual with a mental health problem, and families have been the backbone of all the good outcomes in serious mental illnesses in this part of the world. And caregiver burden is real. So it is very important that we help in managing caregiver distress. And in the remission phase, we need to warn about relapses, the early warning signs, again, psychoeducation, and we must always be available for them to come back if there is a need. So with all these principles, I think I would like to share what SCARF has been doing in rehabilitation over the years. So So that is our founder, Dr. Sharda Menon. I don't think I need to introduce her. Like I said before, rehabilitation doesn't start when the person improves. It starts from the time we come into contact with the system. So, Jen, this is just a brief overview of some of the key activities of rehabilitation that happens at SCARF. I think in more recent times, the mental health recovery program is one very successful program that is happening, which is basically it is based on the lifestyle redesign program principles. So it is solution focused with a lot of positivity, which it empowers people to make choices and achieve behavioral changes in a very sustained way, though it is very slow, small steps with weekly goals, and then they continue it till it becomes a sustained change. So what are the target domains that are addressed here? It could be anything, looking at recovery in domestic work or social skills, physical health, physical activity, leisure activities, spiritual health. People have their own choice. So it is more from their personal interest. It is actually a group program. So as a group, a small group of 8 to 10 people, they meet every week. They set goals among themselves and they make sure that they are doing it on a regular basis. Each of them supports the other person and they meet every week and share their progress. And after a period of 8 to 12 weeks, they are able to see a lot of changes in their lifestyle, which helps them in a lot of ways. No, there are people who feel that they are able to cope with work-life balance better. They're able to cope with their symptoms better. So they're able to handle mood swings or a bad boss at work or whatever. So many people have reported that this has helped them in a big way. Peer support is another thing. As I said, the lived experience being a part of rehabilitation is the most important thing, and peer support works so beautifully well for many people, especially younger people with serious mental illnesses. Talking to a peer is any day better than talking to a professional who can never understand the personal experience of having a psychotic illness. So I think the peer support, it doesn't deal with everything. There is a training that is offered for peer support, and then the peers they're paid volunteers who have persons allotted to them, and they offer support as on need, on a weekly basis. We all know that there are a lot of cognitive, I'm sorry for the spelling mistake. There are a lot of cognitive deficits that can happen, which can start even before the onset of the psychotic illness. And so not all of them are reversible. So we need to have some mechanism in place where people can live and manage with those deficits. So your compensatory cognitive training is again another major activity that we offer. It's part of our clinical, it is there in our clinical services. So people are given a virtual, it is done both in person and virtually, as a group and individually, where it is more a real world setting, and they are given activities by which their cognitive skills get enhanced and they can manage earlier tasks that were difficult for them earlier. So, and the employment exchange cell, again, it has been a very successful thing in the last couple of years. We encourage people who think that they need a job, they can approach us, and we try to fix up employment for them through various contacts. It is still getting streamlined, but it is it has been successful so far. We do some assessment and then we either send them for training and placement or directly for placement. Again, it depends on what the individual needs, because there are people who do not want to reveal their problem to the employer. So when that happens, we have to respect that. And so we just show them the places where opportunities are available and they go find the job themselves. But if there is a difficulty with that, then we do step in and help them to get a job. The vocational training center, I'll come to it. Uh, yeah. Yeah, this virtual physical fitness group was something we started during the COVID time. It was done more for people with the first episode because the metabolic side effects were more alarming for them, and the risk of skipping medication or dropping out of treatment was high with that group. So a virtual physical fitness group really helped. People were able to manage their physical health, their fitness, and they felt much better about themselves. We also do it for people with longer duration of illness, which is again peer driven. One of the person with lived experience will lead the group every day between say about half an hour to 45 minutes in the evening. There is a group and they all connect online and participate in the warm-up exercises and some physical activity. So that is, excuse me, just an overview of the vocational training center, where you have various activities. It could be tailoring, it could be screen printing, or we have that paper plate, sorry, that areca plates and tailoring, and that is a kitchen unit where domestic training is also offered. Now, this is highly individualized. It is supervised by an occupation therapist, and there are work unit supervisors who are also trained, recovered patients, so that they will help other people to perform these tasks better. And there are income generation activity training that happens there. So all these workshops, it could be small things. And now, in recent times, we have found that there are institutions like the Skill India, which is offering a lot of training for people with various disabilities. And one of the, and they are willing to do it for people with mental health problems now. So we have been able to get them to accept to do it for us. And we are trying to, excuse me, establish that as well. So I think in 2025, that should work. So there are a lot of opportunities for people to get skilled in various trades. And so that way, I think occupational therapy and vocational training will help in a big way in recovery. So coming back to the employment exchange, it definitely is a very time-consuming task because it involves a lot of networking, lot of meeting with a lot of people. We need a lot of patience. We need people to understand why they have to consider people with lived experiences for jobs and dispel all their myths and misconceptions. And then we have to line up people who are available for the interviews. And then, so the process goes on. So there are some institutions which help us in giving soft skills training for some of our patients who may not be able to find a job for themselves. So depending on their disability, depending on their ability, the job matching is done, and there's a team that works for that. Yes, coming to the caregiver education program. This is a regular monthly activity where families are invited to participate in a program. Now, earlier, it used to be more of either a talk by one of the social workers or psychologists, and then Q&A sessions. But now it is more theater-based. As you can see in the last picture, there is all relevant scenes, which these are things that can happen in any household. So the concept of forum theater is being used here. And we have a theater team with service users. About 25 people are there, and they can come together. A few of them come together and enact a short skit for about 10 minutes. And then there is a discussion around that play, which helps to convey a message much better rather than by didactic lectures. So this is something that has been happening, and families it helps them understand the lived experiences perspective, and the person with the lived experience is able to understand the family's perspective better. Excuse me. Now, seed funding, this is something we have been doing for a long time, because this the one that happened in Tirupurur was probably around 30 years ago. More recently, people who have received training for some small businesses, they have been given a rolling fund, and they have started small businesses in Chennai. So this again, all this needs a lot of money, and we are happy to say that Flex Foundation gave us the money to run these activities for the past couple of years. Why I'm talking about this here is, when I was talking to a person from Skill India Leather, they said they are willing to give individual training for people with mental disabilities so that they can work on their own in their homes and not place them in competitive employment. And the reason he said was, the supervisors in these factories will not discriminate between a person with a disability and a person who is normal. So they will expect the same kind of output from the person with a disability, and will not give him any kind of concession, which can be very difficult for these people to sustain. So we realize that maybe that is an area we need to really work on, and talk to the supervisors about minimal accommodation that they can consider in workplaces. So that is another, I think Ekalavya could also take this up in the workplaces. So now, how can service users and families help? One, I think just like you're all doing, help in creating awareness, and sharing personal narratives will definitely help in breaking the stigma. I'm very happy to say that SCARF every year on World Schizophrenia Day, on Dr. Sharda Menon's birthday in June, we give out the Sharda Menon Award for people who have coped with their illness successfully. When I say successfully, it doesn't mean they are symptom-free. People who have been leading as independent lives as possible despite their illnesses. Last year, one of the persons whom we identified for the award was a fisherman who lives in a remote village quite far away from where we are. But the fact is, he makes it a point to go talk to people, anyone who he thinks has a mental health problem, and will share his story with them and insist that they seek help. And I'm surprised that he has actually referred about 25 to 30 people over the years, simply by saying, no, you go to this place because I had a problem and I got treated. Some of them might choose to go elsewhere, but the fact remains that he was responsible for many people seeking help. So sharing personal narratives goes a very, very big way for breaking the stigma around mental health problems. And I think in family establishments, families can help in employing one or two people with mental health problems, which can be supportive in both ways. Support forums like this, they are again, they definitely are a very helpful thing. Every time we have a caregiver education program, the people who come there, they come out feeling that, oh my God, I always thought I was alone, and I'm so happy that I can share what I experience. That there is a lot of guilt, a lot of doubts, a lot of fear, a lot of depression about whether they are doing the right thing, or if it was okay for them to do certain things. And all these things, they feel better when they're able to share it with someone who really understands. Just like we have peer support for people with lived experiences, support forums for families is a great way how people can help each other. And it is very important that people with lived experience participate in research. That is very important if we really want to bring about some changes in the way mental health and policies are looked upon. That way, self-help groups are another way of doing things, making life better for people with lived experiences. And the most important of all, I think it would be great if we are able to encourage early help seeking wherever possible, just like the person I mentioned a little while ago. So, from a very restrictive medical model of care to a very open and inclusive rehabilitative model of care, recovery is possible as a whole. Thank you very much for your patient listening, and I hope I have not overshot my time.
No, not at all. Thank you for braving a sore throat and just being with us today. Thank you so much. That was quite mind blowing and quite mind opening, really. So, I kick off with just one question, and then perhaps we can have the others chip in. Now, how can one, recalibrate expectations? A lot of the, I know, the expectations are very high for many patients because they want to function on par. And how can one really say that, yes, now you wouldn't ask a person with a fracture to run a 100-meter dash, but people like who are affected just say, I want to do the 100-meter dash. How can one recalibrate those kind of expectations, doctor?
Okay, so I'm not sure if that I can use that analogy, because yeah, this is a very frequent question challenge that comes up, because there are people who have been highly qualified, people who have been say engineers or doctors or other specialists, in their own field. When they develop an illness, it's very difficult for us to ask them to go and do a job like data entry, or you make paper bags. Those are things that it is very difficult. But then none of these activities are going to be their career. It is only going to be a process where they are going to regain all their lost skills. So, to put it very simply, I think we generally don't expect everybody who comes into the vocational training center to be actively involved in any activity. The very process of getting up in the morning, getting ready, coming on time, and staying here for that specified period of time itself is a discipline. I think that will be the first requirement that anybody will need to have when they have to go back to work. So it is a slow process, and it will happen over a period of time. So even if somebody says, no, I have to go back to my original level of work, we have to encourage them to do smaller jobs first, see if they are able to do it. And I think the biggest challenge will be the people who are in marketing jobs where, the stress really gets to them, it's easier to convince them because they know that they are not able to handle the stress and they may accept what we are offering. But with others, like you say, it is a challenge. We may have to keep working on them and I think after some time they come to terms with, okay, maybe I can try something different, they can hit upon something that seems to be okay for them, then they might accept.
Very true, doctor. Thank you so much. I mean, in my personal experience, also, it has been that way. I mean, I set very high standards for myself. And then I realized that, doing it in part acts, like people say, doing it in small bits, chipping away, and then going to bigger things. I also would like to highlight that diet and exercise are important aspects, and which you touched upon. And I think my personal experience has also been that. I mean, to be able to get into a routine of exercise
Yeah.
and diet. Any other questions? Please feel welcome. Yes, you're on mute.
Yeah, thank you very much, Doctor, for all your detailed explanation about this. Actually, thing is, I had an opportunity to, have a contact with Mr. Ganesh Rajan. So then I got into a group, 6 months back. Actually, my son, had the mental health problem and psychiatric issue, and this was diagnosed, a couple of years before. Actually, he's a BTech in ECE, Electronics and Communication Engineering, and he pursued for a masters in France. And then later on, he was working for a company, there in Luxembourg, in PwC, and also. But all of a sudden, he got into this problem and he returned back. So we found that he has psychotic problem. So currently he's being treated. Actually, this is the second episode in my family. Actually, my elder brother, he's no more now. Actually, he had a similar issue way back in 1972, and then he was a patient of Dr. Sarada Menon, and in Chennai. And we took him to Dr. Sharda Menon, and till and he was in SCARF also for some times. And okay, but we could not able to recover him. But he was doing his day to day work and everything, and he was taking his medicines, everything. My brother, elder brother. But but as far as my son is case is concerned, because it's second in our family, and we are slowly bringing him into normal this one, and with the help of the medicines and as well as this one. Actually, the whatever which we have presented in the meeting, it was really an insight for me, so that it will help myself and my wife to handle him in a better manner, and we can bring him into a normal lifestyle. Yeah, thank you very much, doctor.
Thank you. Yes, I think between 1972 and 2024, there is a lot of advancements in the way psychiatric illnesses are managed. And so I don't think your brother would have had the benefit of some of the better medications that are available in today's field. So I don't think, yeah, a genetic loading is definitely a factor that we have to consider, but still, with adequate psychosocial interventions and proper treatment plans, there is a good possibility of your son becoming better. It all depends on how we are looking at recovery and what is our definition of recovery in our life.
Sure, doctor. I agree with you. Totally, I agree with you, doctor. because between 72 and 2024, there is a, it's a very, there is a huge, difference in the medication and as well as the medicines and all, and it really helps for a faster recovery. Yeah. Thank you, doctor.
Doctor, medicines are taken regularly by me, but sleep in a month, in a day or two, I sleep only for 3-4 hours. It is okay, or we have to think for the sleep continuously? In a month, every time I sleep 8 hours, but I sleep 4 hours in 1 or 2 days in a month. Is it okay?
I'm not sure how I can answer that question because, yeah, but if it is just 1 or 2 days, occasionally, all of us can have less sleep. That is not a bad thing. But if it is going to happen very regularly, very frequently, then I think you will have to discuss this with your treating psychiatrist so that some medication needs to be adjusted or something about your lifestyle. If you are sleeping more in the daytime or you're taking your medication very late or your lifestyle, if it is sedentary or active, I think all these factors will play a role in your sleep.
I don't sleep in the daytime at all.
Okay.
And lifestyle is fully active.
Okay. See, if it is just 1 or 2 days and you are okay with it, if it does not affect your daily routine in any way, you don't have to worry too much about it. But if it is continuing, I think you should discuss it with your consultant.
Thank you, doctor.
Yeah.
Anybody else would like to request or ask doctor, comment or ask doctor anything?
Yeah, I think comments would be welcome. So if I can, I forgot to mention in the course of my presentation, our theater team at SCARF, they have a short skit on at least 2 or 3 days in a week in our OP waiting hall, which is more to educate service users and families about some of the issues that they can face, just like the plays that are happening in the caregiver education program. We have regular plays in the OP waiting hall as well. So actually that again helps people to discuss things that they can't discuss in the consultant's room because it is either too short a time or they are not comfortable talking about certain things with the consultant. Sometimes they don't even know that if it is something that they should discuss with their doctor. So those are all those issues that get discussed in the forum play that happens in the waiting hall. And I think families do benefit from that.
So is this streamed sometimes or is it just in a physical?
No, it's physical. It's physical. The waiting room theater.
Okay.
So it is very physical.
Doctor, I have a question. Hello.
Yeah.
Yes, please.
Actually, I'm suffering from schizophrenia in the start right from 1998 when I graduated in engineering, electronics and telecommunication branch. And after that, I did MBA. I worked with 2-3 multinationals. And recently, I have worked with TCS for the past 16 years. But over in TCS, I dealt with schizophrenia with OCD, obsessive compulsive disorder. And thoughts were coming so much that I was unable to concentrate in my daily work. So I had to quit in the end, and now it's been almost close to 2 years. But that OCD symptoms has not gone down. When I checked up with doctor, they said we have only like the treating psychiatrist told me like doctor in Pune Vadve. So he told me like there are only 2-3 permutation combinations. Maybe there we'll have to try something else. But nothing has significantly worked over time. Even after leaving the job after quarter to near about 2 years. So may I request you for your guidance on that?
Sir, I think that almost translates to a consultation, which I am not sure can happen because I don't know. You are getting treated by a senior psychiatrist in Pune. So sometimes it is not just because you leave your job, it doesn't mean the OCD will go away. The OCD was definitely getting in the way of you functioning effectively. That is what has happened. Maybe you can discuss about therapy, cognitive behavior therapy with your consultant and see if he can recommend someone for you for that. And yeah, can you also look at keeping yourself occupied in some other way? Sometimes the job might have been stressful because of your OCD, but then not having a job and sitting at home is also, it's going to increase your obsessive thoughts a little more because you are, if you're not engaged in something continuously. So maybe you should look at engaging in something, even if it is not a paid job, something where you can volunteer so that there are not major responsibilities. It is a little stress-free for you, but you are engaged in some way. So you could try that and see if that works for you.
Okay, just one second. I just wanted to add to it. Like this OCD, it even became difficult for me to get up on time and to report to doctor also at times. So it is reduced to at least 40% now. But then not coming on time, this is a problem in TCS also. Then I was not able to report on time after taking the medications and all. And I couldn't disclose this mental illness because this was not allowed in my job, like suffering from mental illness for TCS. So that became a big problem of getting into routine and doing the daily things, because unless you're not seeking to a time schedule, and then this thing happened, it becomes very difficult to cope up and live with normal routine. So yeah,
Now,
if
one
you
thing
can.
I can, I know it is difficult for different people, but I think if you are able to reveal your problem to at least one person who is your superior or who someone who can have a say in your work pattern, it would definitely be beneficial for you to sustain in a job. I'm not talking about going back to TCS, but then you could get into another job and see if you can actually have a mentor to whom you can reveal that you have a problem and who can help you in case there is a issue. Yeah, medication, ideally, if it is taken earlier in the evening, will help you to get up earlier in the morning and be to work on time. But like you said, in a corporate, you don't have a very fixed timings like in a government office, so you can't you won't know at what time you're going to reach home. Now, all that is a challenge. So you can look at work from home options. If you can find a job like that, that can help. The work from home definitely helps many people with mental health problems because it reduces a lot of distress that is associated with long duration of travel or dealing with colleagues with whom they are not very comfortable. I think those kind of things are avoided, but it is good actually to have some kind of social contact in a workplace, which is also very good for your mental health. So I think it needs to be, you need to strike a balance between all these factors. I think there
Okay.
was a question in the chat box.
And do slowness in work is a symptom of cognitive symptom of schizophrenia?
Slowness in work is more a negative symptom of schizophrenia. Sometimes it can be combined with cognitive difficulties also, but usually it is because of negative symptoms or medication side effects, like the Parkinsonian side effects of medication that can also lead to slowness. I think there was a question about persistence of negative symptoms. So persistence of negative symptoms, over dependence on caregiver, how to overcome. Yes, negative symptoms is always a challenge because positive symptoms are better controlled with all our existing medication. Negative symptoms have a few medicines that will help, but then more importantly, psychosocial rehabilitation plays a very big role in managing negative symptoms. Because for someone who doesn't socialize, someone who doesn't have motivation, someone who doesn't talk much or is very apathetic to situations, I think there we need someone to literally goad them, push them, make them do things. And that will happen only in a psychosocial rehabilitation setting, and it will not happen with just medicines. Medicines are needed, but then you also need some kind of a rehab input there. Dependence on the
Dr.
caregiver.
Rukatikar, you're on mute. Dr. Rukatikar, you're on mute. I'm sorry, Dr. Rukatikar, for some reason we can't hear you. Okay. Well, we don't seem to be having Dr. Rutiger audio. We only have his video. So, well, we've reached the end of our session, and I think there are some important takeaways, and I would like to also add to what Dr. Mangala said, that today we have you know, different options for work, online options for work, and not necessarily to be physically present. There are gig aggregators for people with some talent. For example, IT talent, they can work at home and the hours of their choosing, and gig by gig. That means project by project. And I'd like to close with a little bit of a tough question, Dr. Mangala, which is basically how do we tackle with existential questions? You know, you just start touched on it. Why me? Why? But what is the best way to come out of that kind of a cul-de-sac?
No, I don't think we can come out of it at all. I think it is a question that we need to face, but then, I mean, every time I see an elderly parent walk into the room, I dread. I dread that question will pop out of his mouth any day. I don't think anybody has the answers for that, but I think that is where now people are planning on forming trusts, making sure. I think the family pension schemes, now where the father or the mother being a government pensioner, the the son or daughter with a mental health problem becomes eligible for the family pension. So financially, there is some kind of support, but then that is not enough. Some parents would want to know for sure that that child will be well taken care of. Yeah, a trust that is formed with people who are there, someone they trust. Uh, it could be a family member, it could be a lawyer, or it could be court appointed. So someone who can make sure that this person has a comfortable life and has access to services, access to care. All this should be planned by the families way ahead. And for that question, who after me? Normally, what we would suggest is involve one other family member right from the very beginning of the start of the problem. Because we know the story is always like this. It is the mother who ends up being the primary caregiver, or it is the father. And the rest of the family, not because they ignore, they are not in the picture most of the time. It is ideal that we involve one other sibling, male or female, in the picture in the beginning, so that when a day comes that they have to take over, they don't feel paralyzed, not knowing what to do. That way, the transition will become easier if they are involved in the care in the very beginning. This is something we always insist when we have aging parents taking care of middle-aged or young wards. So definitely, yeah, if people are married, I think it is kind of addressed, not fully, but then more or less it somehow some kind of help is available in some form. May not be great, but it is definitely available. But that existential cul-de-sac, no, there is no way we could escape from it.
Thank you, Doctor. Thank you very much for being with us and sparing your valuable time. That was really, we took away some things, especially on the adjunct practices, which are important. As a person would say, 33% is pharmacological, 33% is psychological, and 33% is really the network, the social network, which helps us. Thank you so much for being with us. We will be posting this session on YouTube, and people who have come in late or would like to refer this talk to others are welcome to do so. We will be in touch soon. Thank you very much again. Really appreciate.
Thank you. Thank you for the opportunity, Ekalavya and Ganesh in particular. I think it was an evening well spent for me, and I hope all of you, all the others also feel that way. And I would definitely like to be more associated with your organization in the future.
Thank you.
Thank you
Thank
so
you,
much.
Doctor.
Take care,
Thank you so
Doctor.
much.
Thank you. Thank you, Ganesh ji.
Yeah.
Thank you. Thank you.